There's of risk factors in vascular disease, certainly smoking, hypercholesterolemia, diabetes, and then family history or genetics. And any one of those can predominate one over the other, or occasionally people won't have any of them, but almost all of our patients will have at least one of those risk factors, and some of them have all of them. So when I talk about things like lifestyle modification and how you can reduce your risk for problems down the road, not eliminate, but reduce, well, I tell my patients, control the things that you have the opportunity to control, because there are other things that you can't control. You can't pick your parents. To some extent, you can't, pick whether or not you're diabetic. But, in terms of diabetes, you can work as hard as you can to control your sugars and manage it. You can try to control your cholesterol, either through medication, diet, or both. And smoking, well, you can choose to stop smoking. I will not make any claim that it's easy, but if I didn't tell my patients to do it, I wouldn't be doing my job. So the plaque formation in arteries is primarily an inflammatory process. So many diseases in our body are secondary to inflammation, and in the arteries, even as young as in the teen years, in some cases, we start to deposit bits of fat. They call it a fatty streak, and our Western diet doesn't help with that. But that once that bit of fat on the inside of the artery is there, it can induce inflammation, and that inflammation then just starts to slowly take its effect. Various cells that we have will elaborate these proteins that are pro-inflammatory that can cause deposition of calcium and additional fatty plaque, cholesterol plaque inside the arteries, and it just slowly builds up over time. And it's kind of a vicious cycle. The presence of plaque tends to induce more plaque. It creates more inflammation, and that artery will slowly close up at some point. If it gets severe enough, the artery can just occlude entirely, and the flow will stop, and that's when people, will become much more symptomatic. If it happens slowly over time, they'll gradually notice increasing symptoms. If it happens suddenly, well, that's the kind of patient that rolls into the ER, and they're in trouble in terms of their circulation to that extremity, and they need to have something done immediately. There are different imaging technologies we use. Of course, it always starts with history and physical. Many times you can just talk to the patient, and what they're describing to you, you can almost predict where the blockage is going to be. In the same way, sometimes patients will come to see you, and they think they have a particular problem, but their story doesn't line up with that. Something else is going on. So that's important. Always start with that. And then we do use imaging modalities. Ultrasound is extremely important. We have a fully accredited vascular ultrasound lab here at PCI, so that's very convenient for patients to come in and get studies done. Other principal means of imaging, CAT scans are very useful. 15, 20 years ago, the CAT scan technology was far less advanced than it is now, and the arterial studies were not as good, but now they are just excellent, and have become a crucial aspect of working patients up and determining how we want to manage them. And we have state-of-the-art CT scanners here at PCI, so we will work very hard to schedule patients to have their CT done, and then they just come right over to the office. We can look at it and talk to them about the results immediately. Many cases, we still do perform bypass operations to deal with these kinds of blockages, but that's far less common. After all, we used to have to perform a bypass on every one of these blockages before these endovascular technologies even existed. Now it's a minority of them, and it tends to be more advanced disease. It would be rare for a patient to progress to a bypass without having first had some minimally invasive types of procedures. The problem, of course, with vascular diseases is that they don't just go away. It's different than, say, for example, if you have appendicitis, you can have your appendix taken out and you will never get appendicitis again. It doesn't work that way with vascular diseases. The disease processes that are in place that cause the problems don't just go away because we operate on a given vessel. Those things will continue. Medical management, lifestyle modification, those are all really important aspects of it, but it's almost impossible to completely eliminate the risk factors. So we follow patients really for the rest of their life. We want to keep track of things, make sure that we know what's going on in case they need to have something else done.